Right now, thousands of people are, walking into mall tattoo parlors, sitting down in a leather chair, and letting a teenager drive a 16-gauge needle right through the thick cartilage of their ear.
And they are definitely not doing it just because it looks cool.
No, exactly. They're doing it because they actually believe it is a permanent cure for debilitating chronic migraines. And, I mean, if you spend even 5 minutes looking this up online, you're going to find just a mountain of videos, people crying tears of joy, claiming this one simple piercing totally gave them their life back.
Right. But then if you ask major medical bodies about it, they will tell you this is scientifically impossible, like zero clinical evidence.
Yeah, so we have this massive collision today. On one side, incredibly passionate anecdotal success. On the other side, cold, hard, clinical reality. So who is actually right? Okay, let's unpack this.
To really figure that out, we have to look past the viral social media algorithms and dig into the actual physiology of chronic pain.
Right, the real science.
Exactly. We're unpacking data today from the American Migraine Foundation, the Cleveland Clinic, and a really comprehensive 2024 systematic review from the journal Headache. And what emerges from these sources, it's just a fascinating story.
It really is. It's this wild intersection of misplaced anatomy, the desperate psychology of pain, and how our own brains can, well, essentially trick us into feeling better.
Which is incredibly powerful. But we should probably start with the piercing itself.
Right. We are talking, of course, about the Daith piercing. So for anyone unfamiliar with the geography of the ear, the Daith is that tiny, super tough fold of cartilage situated right above the opening of your ear canal.
Medical texts usually refer to it as the crus of the helix.
Crus of the helix, right. It's basically where the innermost rim of your ear cartilage curves back and sort of fades into the bowl of the ear. So Daith piercing punctures horizontally right through that little ridge, usually, holding a captive bead ring or maybe a small curved barbell.
And it's funny because back in the early 1990s, this was strictly a grunge fashion statement. It was edgy, cosmetic. Nobody was claiming it had medical properties back then.
No, not at all. The shift from, an aesthetic choice to a viral medical intervention really only gained momentum maybe a decade ago.
Yeah, and the driving force behind that shift is rooted in an attempt to borrow credibility from a much older tradition, which is auricular acupuncture.
Right.
Proponents of the piercing lean super heavily on this concept called vagal neuromodulation to explain why puncturing this specific piece of cartilage supposedly shuts down a migraine.
Which, vagal neuromodulation sounds incredibly clinical and sophisticated for a procedure done next to a mall food court. Are they literally trying to hack the vagus nerve with a piece of jewelry?
That is exactly the working hypothesis. So auricular acupuncture operates on the premise that the outer ear is essentially a microsystem mapping the entire human body.
Like reflexology, but for the ear.
Basically, yeah. This system was heavily formalized in the 1950s by a French physician named Paul Nogier, and he mapped the ear to resemble an inverted fetus.
Oh, wow. Okay.
Yeah, so the lobe corresponds to the head, and that inner concha region, which is right where the Daith piercing is located, that loosely maps to the autonomic nervous system and the internal organs.
Which are governed by the vagus nerve.
Exactly.
And there actually is a real anatomical basis for the vagus nerve being present in the ear, right?
Yes.
Like the source material mentions this really quirky proof involving cotton swabs.
Arnold's nerve reflex.
Right.
It is a brilliant example of this anatomy in action. So the vagus nerve is one of the most complex cranial nerves. It wanders from the brainstem all the way down through the abdomen.
It's huge.
Massive. But it does have this one small sensory branch that surfaces in the outer ear. So when you're, say, cleaning your ear with a cotton swab and you suddenly feel a tickle in your throat, that makes you cough.
Yes, I've totally had that happen.
Right. That is Arnold's nerve reflex. You are mechanically stimulating that branch of the vagus nerve, and your brain basically misinterprets the signal as an irritation in your throat.
Which is wild to think about. Your brain just completely gets confused about where the physical touch is actually happening.
It does.
So, okay, following that logic, the proponents of the Daith piercing claim that driving a needle through this specific cartilage fold and leaving a metal ring there provides constant stimulation to this exact same vagus nerve branch.
Right, and that covers the local stimulation part. The theory then traces that signal from the outer ear deep down into the brain.
Okay, where to?
The sensory input from the vagus nerve travels to a structure in the brainstem called the nucleus tractus solitarius.
Okay, that's a mouthful.
It is. Just think of it as a central routing station for sensory information.
So the signal hits that routing center, And then where does it go to actually stop the headache? Because, routing center doesn't do much on its own.
Right. From the nucleus tractus solitari, the signal is theorized to project to and inhibit the activity of the trigeminal nucleus caudalis.
Okay, the trigeminal, that sounds related to the trigeminal nerve,
Hmm.
which I know is a major player in facial pain and migraines. Is that the specific region that processes the migraine agony?
Yes, it's the primary relay station for pain signals originating from the head and face. During a migraine, the trigeminal nucleus caudalis becomes highly sensitized.
Just firing off constantly.
Exactly. So the hypothesis advanced in a few published case reports is that constant vagal stimulation from the piercing essentially sends an inhibitory signal, like a calm down message, to that trigeminal relay station.
Shutting off the pain loop.
That's the idea.
I have to admit, the underlying logic of that is deeply satisfying. It sounds like flipping a breaker switch in your ear to turn off a blaring alarm system deep inside your brainstem.
It's a very appealing mechanical explanation.
Yeah, if the body actually works like a predictable electrical grid, it makes total sense. But taking a step back here, acupuncture is an incredibly precise discipline. Practitioners spend years learning to map these microscopic nerve clusters and meridians.
Years. Yes.
How does a piercer, who's primarily trained in aesthetics and, blood-borne pathogens, know exactly where to hit this microscopic nerve branch?
Well, what's fascinating here is that the 2024 systematic review in the journal Headache looked exactly at that question. They compared the typical Daith piercing site against both Western and Chinese auricular acupuncture maps.
And what do they find?
They completely dismantled the anatomical argument. The standard placement for Daith piercing is, on average, a full centimeter away from the targeted vagal acupuncture points.
Wow, a centimeter.
Mm.
Which doesn't sound like much until you remember we were talking about the landscape of the inner ear.
Right, in the ear, it's huge. A centimeter is a massive distance. It's like dialing a 10-digit phone number perfectly, but getting the very last digit wrong. You aren't getting a slightly different version of your friend. You are connecting to a completely different person.
A completely different person, or no one at all. Because piercers do not use anatomical landmarks or nerve mapping devices to place this jewelry.
They're just looking at the ear.
The technique is purely cosmetic. They are analyzing the shape and thickness of your individual cartilage fold to ensure the ring sits flush, looks symmetrical, and, won't reject.
They're optimizing for aesthetics, not neurology.
Exactly. And even if a piercer miraculously slipped and hit the exact anatomical bullseye by sheer luck, our sources point out a fundamental difference in the type of stimulation being applied.
Oh, like the needle itself?
Yeah. Acupuncture uses incredibly fine needles to provide targeted, intermittent stimulation. A piercing is a thick piece of surgical steel or titanium, creating a permanent, constant pressure.
And nerves don't really respond to constant pressure forever, right? No, our nervous system is exceptionally good at tuning out constant, unchanging stimuli. It's a process called sensory adaptation.
Like when you put on a watch and then forget it's there.
Exactly. It is the exact same reason you stop feeling the weight of a watch on your wrist after a few minutes. Even if the piercing sat directly on the nerve, the continuous low-level pressure of a captive bead ring is a fundamentally different neurological event than the precise intermittent modulation of clinical acupuncture.
So it just fades into the background.
Yeah, the headache review was unequivocal on this. The anatomical and physiological evidence simply does not support the piercing as a functional intervention for the vagus nerve.
Okay, so if the needle is hitting the wrong anatomical phone number entirely, and the type of physical pressure is fundamentally useless for long-term nerve modulation anyway, why are there so many videos of people looking into a camera, weeping with relief, saying their migraine vanished the second the needle went in?
Are we just tricking ourselves?
Yeah, are they faking it for views?
They are absolutely not faking the relief. The pain reduction they experience sitting in that chair is very real, but it operates through a completely different physiological pathway than vagal neuromodulation.
Okay, what is it then?
It relies on a phenomenon known as diffuse noxious inhibitory control, or DNIC.
Diffuse noxious inhibitory control. That is some heavy medical jargon.
I know, but the underlying concept is beautifully simple. It's often summarized in pain literature as pain inhibits pain.
Pain inhibits pain.
Okay, when your body receives a sudden, intense, noxious stimulus, like a thick needle crushing through dense cartilage, your spinal cord and brainstem react immediately. They activate descending pain inhibition pathways, flooding your system with endogenous opioids.
Oh, wow.
Yeah, and it essentially gates off other pain signals to help you deal with the immediate acute trauma.
Okay, wait, this is the classic stub toe mechanism.
Exactly.
You stub your toe on a coffee table, it is blindingly painful, and without even thinking about it, you bite your lip really hard.
Yeah.
You create a secondary intense pain to scramble the signal of the first pain.
Your brain can only focus on one screaming alarm at a time.
So getting a needle through the ear is just biting your lip for a migraine.
That is the exact mechanism. The procedure of getting a cartilage piercing is highly noxious. It hurts a lot. That acute trauma produces a powerful systemic wave of pain modulation. The brain temporarily turns down the volume on the migraine to process the trauma happening to the ear.
But the key word in that whole process has to be temporarily, right? I mean, a stubbed toe stops hurting eventually, you stop biting your lip, and the body's alarm system resets.
Right. As the cartilage begins its slow healing process and the acute inflammation subsides, that descending pain inhibition naturally fades away.
The brain stops suppressing the baseline pain.
Exactly. And this perfectly maps onto the most common anecdotal timeline we see with Daith piercings. A period of miraculous, immediate improvement for a few weeks, followed by a quiet, gradual return to their historical migraine frequency.
That perfectly covers the acute physical shock of the needle.
Mm.
But we also have to dive into the psychological layer here, because the American Migraine Foundation and the Cleveland Clinic lean heavily on a different mechanism to explain the longer-lasting relief some people report.
Yes.
We are talking about the sheer power of the placebo effect.
And this is huge. Migraine as a disease state is uniquely responsive to expectation, belief, and the context of treatment. In randomized controlled trials for new pharmaceutical migraine drugs, the placebo response rate consistently hovers between 20 and 30%.
Wait, really? That means nearly a third of chronic pain sufferers experience a genuine, measurable reduction in their agonizing symptoms simply because they believe the sugar pill they swallowed is a real medication.
Yes. And we know from decades of placebo research that the more invasive, dramatic, or memorable a sham intervention is, the stronger the placebo response will be.
Which makes sense.
Right. Swallowing a pill is a passive, mundane act. But going to a studio, sitting in the chair, enduring the pain, and leaving with a permanent, visible modification to your body that is a highly salient ritual.
Yeah, every single time you brush your hair, every time you look in the bathroom mirror, you see this piece of metal. It serves as a constant physical talisman, reminding your brain, I took action. I did something radical to fix this.
Exactly.
That has to be an incredibly potent psychological anchor.
It creates a tremendous expectation of healing.
Yeah.
And when you combine that potent expectation with the natural life cycle of the disease itself, you create a perfect storm for misattributing the cure.
Oh, so?
Well, migraine frequency is not a flat line. It is deeply cyclical. It waxes and wanes based on stress, hormonal shifts, sleep architecture, barometric pressure.
Right. You don't seek out a painful, permanent body modification when you were feeling great. You don't get a Daith piercing when you've been migraine-free for a month. You do it when you are in the middle of a 2-week cluster attack and you are absolutely desperate for anything to make it stop.
Which brings us to a statistical phenomenon known as regression to the mean. If a patient is at the absolute peak of a severe migraine cycle, they are at the extreme end of their personal pain spectrum. Statistically, the symptoms are highly likely to improve in the near future simply because they cannot get much worse.
They have to bounce back eventually.
Right. They regress back toward the patient's baseline average.
So let me synthesize this. You go to the mall on day 14 of a terrible pain cycle. The migraine was naturally going to break on day 16 anyway because of this regression to the mean.
Yep.
But because you introduced a radical new variable, the piercing fight, you assign 100% of the credit for that natural relief to the metal ring in your ear.
You attribute a natural biological fluctuation to a cosmetic intervention. When you combine the acute distraction of pain, inhibiting pain, the massive psychological expectation of the placebo ritual, and the statistical reality of regression to the mean, it is incredibly easy to see how a patient's own brain tricks them into believing they have found a miracle cure.
It's the perfect storm.
Oh.
But the sheer volume of these success stories online is staggering. I mean, the sources mention one specific, frequently cited survey where 47% of people who got a Daith piercing reported an initial decrease in their migraine frequency.
Almost half.
Nearly half. How does that data fit into all this clinical skepticism?
Well, we have to evaluate how that data is generated and, more importantly, how it survives on the internet. Social media algorithms are essentially built to amplify reporting bias and survivorship
Oh,
bias.
because the algorithm loves a miracle.
Absolutely. If you have suffered from migraines for 10 years, you get this piercing, and you suddenly have 3 completely pain-free weeks, you are ecstatic.
You're instantly filming a TikTok video, showing off the jewelry, telling everyone they need to go get one right now. You want to save other people from the agony you've been living in.
And that initial wave of euphoria creates highly engaging viral content. But what happens 3 months later?
Right.
The cartilage has healed, the acute counter-irritation is long gone, the psychological novelty has worn off, and the daily grind of chronic migraines returns.
And you definitely aren't setting up your ring light to film a retraction video while you are lying in a dark room with an ice pack on your head. You just retreat back into managing your illness.
Exactly. The people who experience a return of their symptoms go silent. Furthermore, the people who got the piercing and experienced absolutely zero relief from day one are highly unlikely to post about it at all. They often feel foolish for buying into an internet fad.
Yeah, that makes sense.
And the subset of people who develop severe complications certainly aren't bragging about it. So the internet functions as this massive filter. It captures a permanent snapshot of temporary euphoria while completely discarding the long-term reality of the failures.
The visible anecdotal record becomes incredibly skewed.
Extremely skewed.
Okay, but I'm playing devil's advocate here. Someone listening right now who suffers from chronic migraines is probably thinking, I don't care if it's an algorithm, a statistical illusion, or a placebo, I am in agony. If a piece of metal tricks my brain into giving me even a month of relief, what is the actual harm in just trying it?
And medical professionals get deeply concerned by that exact what's the harm mentality, because a cartilage piercing is not a benign, risk-free procedure. The sources are incredibly clear on this point.
Yeah, this isn't like getting your earlobes pierced with a gun at the mall when you were 12. The tissue is completely different.
Vastly different. The crust of the helix is dense avascular cartilage. Avascular means it lacks the robust, direct blood supply that you find in the soft tissue of the earlobe.
Okay, and why does that matter?
Because blood flow is what delivers immune cells to fight off bacteria and nutrients to rebuild damaged tissue. Since cartilage lacks that blood flow, infections are significantly harder for the body to fight off.
So a minor irritation can quickly escalate into a serious problem.
We see cases of cellulitis and, more specifically, perichondritis, which is a severe infection of the tissue covering the cartilage.
Ouch.
Yeah. Because of the poor vascularity, cartilage piercings take an exceptionally long time to heal. You are looking at often 6 to 12 months of active tenderness, and if a severe infection does set in, it can lead to cartilage necrosis.
Meaning the tissue actually dies.
The tissue dies, leading to permanent cosmetic deformity. It's often referred to as cauliflower ear.
Leaving a permanent disfigurement long after you've given up and taken the jewelry out. And again, this medical risk is being overseen by someone with a piercing needle, not a medical license.
Exactly. Piercers are using therapeutic, medical-sounding language to sell a cosmetic procedure. There is absolutely no clinical oversight if an infection begins to brew, and no accountability for the medical claims being made.
Which makes it so important to contrast this internet fad with actual evidence-based treatments. I mean, the landscape of migraine treatment has exploded in the last decade. We have therapies that actually address the mechanism of the disease.
We really do.
Like the CGRP inhibitors. I know those have been a massive game changer in neurology, but how do they actually operate compared to just hoping a piercing magically hits a nerve?
This is where we see the difference between guesswork and precision medicine. CGRP stands for calcitonin gene-related peptide. It is a specific protein heavily involved in pain transmission and inflammation in the meninges, which are the protective membranes surrounding the brain.
Oh.
During a migraine attack, the trigeminal system releases massive amounts of CGRP.
So the protein is basically acting as a chemical messenger, screaming at the blood vessels in your brain to swell and cause pain.
Exactly that. CGRP inhibitors are monoclonal antibodies designed to act like a highly targeted molecular shield.
A molecular shield. That sounds incredibly sci-fi.
It's amazing technology. They circulate in your system and either bind directly to the CGRP protein to neutralize it, or they bind to the receptor site, blocking the protein from docking. They physically intercept the pain signal at a molecular level.
That is fundamentally different. One is a targeted molecular shield built to intercept a specific biological messenger. The other is wearing a blindfold and driving a needle through your ear, hoping to distract the brain.
And CGRP inhibitors are just one option. We have triptans that effectively abort acute attacks by targeting serotonin receptors to constrict those swollen blood vessels.
Right.
We have Botox on botulinum toxin A, which is FDA approved for chronic migraine. It isn't just for smoothing wrinkles, it is actively taken up by the nerve terminals to block the release of neurotransmitters that carry pain signals from the head and neck to the brain. And for patients whose migraines are driven by specific anatomical nerve compression, there are peripheral nerve decompression surgeries performed by actual surgeons, not piercers.
But what if a listener is still deeply fascinated by the vagus nerve theory? The idea of vagal neuromodulation is inherently cool. Is there a safe, legitimate way to explore that without risking, an ear deformity?
Absolutely. The medical community has developed non-invasive vagus nerve stimulators. They're often abbreviated as NVNS devices, like the GammaCore.
GammaCore.
These are handheld devices that you press against the neck to deliver mild, calibrated electrical stimulation directly to the vagus nerve through the skin. They require a prescription, but they are backed by actual device-based clinical trial data proving their efficacy and safety.
And no cartilage puncture required.
Zero.
And if you really want to explore the auricular acupuncture angle, our sources point out the obvious solution.
Yeah.
Go visit a licensed, trained acupuncturist.
Yep.
They understand the complex map of the ear. They use sterile, hair-thin needles to hit verified anatomical points with precision, and they don't leave a permanent piece of surgical steel tearing through your avascular tissue.
Auricular acupuncture, when performed by a clinical professional in a sterile environment, has infinitely more supporting clinical evidence and a significantly lower risk profile than a Daith piercing ever will.
So, to summarize this wild journey we've been on today, what started as a gritty 1990s fashion statement somehow morphed into a viral medical myth driven by the social media algorithm. And look, the desire for a quick, visible, permanent fix to a condition as agonizing, invisible, and exhausting as chronic migraines is entirely human.
It is. The desperation makes total sense.
But when you pull back the curtain and look at the cold, hard science, Daith piercings rely on a messy cocktail of misplaced anatomy, temporary counter-irritation, the natural ebb and flow of the disease, and a massive potent dose of the placebo effect.
And because we are discussing medical treatments, pathology, and diagnoses today, I do need to provide a very clear disclaimer regarding this deep dive. This discussion is intended solely as an educational resource. Medical decisions must be individualized based on current evidence-based guidelines and clinical judgment and directed by a physician.
Thank you. I want to leave you with one final thought to mull over, building on the underlying psychology we've uncovered today. We started out looking for a physical cure, a needle hitting a nerve. But what we found instead is a testament to the staggering power of the human mind.
Absolutely.
The brain's own internal pharmacy is so potent, so eager to heal, that the sheer expectation of a cure, driven by a few viral TikToks and a simple piece of cosmetic metal, can genuinely suppress the agony of a severe neurological event, even if just for a short window. If a misplaced needle and a strong placebo can unlock all of that endogenous pain relief, what does that tell us about the untapped, incredible potential of our own brains in regulating our suffering? Think about it. We'll catch you on the next deep dive.